Lisa, you guys can still see? Okay, thanks. Sorry, I didn't think I was gonna have so many technical issues. Teams is a little different than Zoom for sure. Okay, yeah, sorry. Back to it. Just the land acknowledgement, obviously, that we do at HCA. This is our general, and I like to read my own just because I've developed it over the years. And I welcome anyone if you want to do our future ones. I think it's always nice to hear other people's land acknowledgements, but I'll just go ahead and read mine that I've developed over the years. So I'm honored to live, grow in relationships, and create on the unceded sovereign lands of the original people of what is now called New Mexico. With a full heart and clear intention, I commit to ongoing learning and to the hard work of dismantling settler colonial ways of being and doing. My foundation, whether in practice, justice, work, or growth, is grounded in historical truth, reconciliation, stewardship, and restoration. I affirm the sovereignty, governance, cultures, language, and spiritual traditions of New Mexico's indigenous peoples, traditions that have been systemically attacked through centuries of colonial erasure, and I remain committed to honoring these truths and to walking a path of equity with action and not just words. So that's my own personal land acknowledgement. I welcome anyone, for future meetings. I just like to hear other people. So if you would be interested, go ahead and let me know for the next meeting we have. Okay, and as we always do, right, we have our mission, vision, and goals for the Primary Care Council. So it's obviously a nice way to start our meetings, just to remind people what the intention of this group is. And what the goals that this group have started working on through our strategic plan. This other one is also just very specific to the House Bill 67, just in case people aren't familiar. I think Elisa created the last meeting, and I really like it because it just really highlights some of the very concrete requirements for this group. So this is our agenda for today. If anyone saw the one I had attached early on, there's a slight change. We were going to review our bylaws and potentially vote to pass them today, but I think we still have some work to do on them. So we're gonna push that back to our next quarterly, and we might do some email over it in the meantime. So this is our agenda today. We may end a little bit early since we just removed that this morning. And you should be able to find in the chat also the agenda attached and the PowerPoint if you want to follow along that way. Okay, so for today, I think, as it always has been, these are kind of the rules for this meeting, right? It's for our Primary Care Council core members, breaks for people as needed, right? It's a long meeting. So if you do need to take a break, we will have one, as you see in the agenda, for everyone if they need at that point, but obviously take breaks as needed. And I added this one just because I think it's helpful for me. If you all have specific things that you think of, as we're talking about different things and we have our different presenters, go ahead and just send me a chat or email. I can just gather those as we go. It makes my job a little bit easier if I know what folks would like to hear at our future quarterly meetings. Also, just because it is a large group, using the hand raise in the chat is really helpful if you can. And also for public comment, that's where we keep our public comments, is in the chat space as well. Okay, I'm going to pass it to you, Val.
Thank you. Good morning. First, I just wanted to really thank and acknowledge both Justin and Elisa. I know there's a lot of work that has been happening between meetings. The work groups have been meeting frequently, and just maintaining all of those agendas and minutes and keeping everyone on track is a heavy lift for Tristan and the team. So really appreciate everything that HCA and the state are doing to support the work of this group. And also to the members. I think that, again, we're working hard to have the work groups doing some of that important work between meetings. And it's challenging, right? Because people have very busy schedules, full-time jobs that we're all trying to do, in addition to the work that's happening here. And so for myself, I'm just trying to remember how incredibly important the work that the PCC is doing is, and to make sure that I'm prioritizing that in the list of lots of other things that feel really important. But I know that the work that we're doing here is really key. And as we'll hear about, there are some exciting positive developments, and I know also a lot of concern and things that we don't know yet about some of the federal budgetary changes. So I do think this is a really important time for the PCC to be active and working hard to both continue those significant advances that we're making in primary care delivery for New Mexico, and also making sure we're doing everything we can to preserve those in what may be a uncertain environment going forward. So really appreciate everyone today. We're going to do a lot of good work around really understanding the PCC priorities specific to the work groups, and appreciate everyone's engagement, ideas as we work to transform primary care.
Thanks, Val. Forward. I'll pass it to Elisa.
Hi, thanks everybody. It's so nice to see a lot of familiar faces and new faces today. You all know I'm so passionate about this work, and Tristan's doing a great job of carrying it forward. So thank you, Tristan. I wanted to give more of an update today, but I think you all are aware that the OBA bill, the big, beautiful bill, or the reconciliation bill, was signed recently. And we at HCA are really in the middle of analyzing the bill and really understanding how it's going to impact us as an agency, our customers, Medicaid, SNAP, and our providers here in the state. And until we really do that work of analyzing the bill and really understanding how it's going to affect us, I don't have anything quite yet to share. I was hoping to have something more official to share today, but it's just not ready. So just know that we're working on it. We are going to have more information coming out in the coming weeks, months, and I'm happy to come back next quarterly PCC meeting when we do have something more official that I can share. If you do have specific one-off questions or things that you're curious about, feel free to email me or Tristan or both of us, and we can get back to you when we have that information. So again, I wish I had more to share at this moment. Ruby Ann, did you want to say something?
Yeah, hi, thanks.
Hi, nice to see you.
Nice to see you too. A question I had was, we're all talking about Medicaid staff, all the, the costs to the agency, all of that stuff. But a component piece that I haven't heard, and of course people are talking about hospitals and all, but a component piece that I haven't really heard people talk about that much, and I think we really do need to talk about, especially for New Mexico, is FQHCs.
Mm-hmm.
And because that's gonna, everything, as the hospitals have issues, uncompensated care, undocumented, all of that is gonna flow to the FQHCs. And I haven't really heard anybody talking about them as a discrete sort of group and concerns there. So I just wanted to put that in as you're looking at the numbers at HCA, and I thought that might be a subcategory that we need to all look at costing out as best we can. Thank you.
Thanks, Ruby Ann. We'll do that. And Ruby Ann, do you want to just introduce yourself really quick so people know who you are? I think we have new people on the phone today.
Okay, hi everybody. I work with Ruby Ann Esquivel. I work with the Legislative Finance Committee. I'm a principal analyst here working on health and human services issues, and I've worked on these issues for many, many years, and I worked at HSD and DOH also for some years. So pleasure to be with you all.
Thanks, Ruby Ann. And Oliver, if you want to introduce yourself first and then make your comment or question.
Sure. Can you hear me okay?
Yeah.
Okay. I'm Oliver Hayes. I'm the Associate Dean for Graduate Medical Education at Burrell College of Osteopathic Medicine. Just based on Ruby Ann's comment, I was at a session about 2 weeks ago where they were talking about Secretary Kennedy's thoughts on health and human services. And apparently he is proposing taking some units within health and human services and folding them all into one unit on chronic disease. And one of those is HRSA, which is important in graduate medical education because they fund FQHC residency training. And so I think that's a potential threat if that division goes away. And I just wanted to mention that when Ruby Ann brought up FQHCs, I was sort of watched that very carefully. Thank you.
Thanks, Oliver. And thanks for saying that too. You know, we have the signed bill, which is going to affect how we do our work. But then there are other things that are potentially in the pipeline that we're watching. So thanks for calling that out. I hadn't heard that. So if you all hear of things and you're concerned about them, feel free to email Tristan and I, just so we can keep an eye on those things and watch the news and follow along with what's going on. Matt, do you want to introduce yourself and then speak as well?
Sure, I'm Matt Probst, and I'm Director of Rural Engagement for the people of New Mexico. Appointed in a position that is through the UNM Office for Community Health. So that's the hat I wear. I'm paid to wear to come here. So like Val said earlier, man, you know, leverage your employers to give you this time because we're doing this for them. And yeah, I would just say as a provider that still gets to see patients, I met early this morning with Dr. Randy Brown, who's the CEO of an FQHC, Sunrise. And there's nobody in his organization that worked for an FQHC before the Affordable Care Act except me. So I know what that's going to look like and feel like. I don't have to guess. And it means that a third of our patients are going to be uninsured and on sliding scale again. And the impact on that to every other tentacle in the healthcare system is going to be wild. It's going back in time. I appreciate the presentation at the beginning, and it just feels for me after a whole lifetime of fighting for rural health, like somehow we're destined to struggle. That's how defeated I feel. But on the other side, I'm built to struggle. So good luck killing me. People have tried and it doesn't happen, and I don't quit. So we will endure. So I want to leave that on a positive. That being said, how has to be very strategic. So I appreciate the comments on that, specifically around FQHC and the impacts there. And then specifically on workforce, as I just got off the phone with Andrea Lazaro, preparing for many presentations at LHHS on July 21st through 23rd in Las Vegas, including one on Semillas de Salud, the Grow Your Own Healthcare Professional program that was once a pitch for the people here and thought might get funded, that still is not funded. That the ability to do those programs, not just for residencies, as we now plan our psychiatry residency in this region, not just for residencies, but for every component of the pipeline, all the way down from middle school, all the way through to residencies, takes a huge hit. And so there is a like, well, can we survive the 4 years? But the impact now has a generational impact. And so, yeah, I very much appreciate that. And, you know, at least when I could say I've been there, done that, I'm ready to do it again. I'm not going anywhere, but it is sad that we're going backwards, but hopefully it's only temporary. And by the end of my career, maybe 40 years into my career, I'll finally see us being able to thrive as rural people and to have the opportunities that other people have been provided. But this problem is nothing new. It's ancestral. So I hope so, but I'm not keeping my fingers crossed.
Thanks, Matt. What I've learned from you all of you PCC members, is that we are very scrappy here in New Mexico. And so we take on these challenges and we do our very best because we really care about the people here. And I have all the confidence that we will continue to do this in this new environment. So thanks, Matt. Let's go to the next slide. Maybe. Tristan.
Sorry, I don't know what the
That's okay.
delay is. There it goes.
Sometimes we have a lot of people, it can delay a little bit.
Yeah.
All right, so here's some good news. We are continuing our graduate medical expansion work, which Oliver and Matt are closely tied to as well. And so since 2019, we have added 3 new accredited programs. And we are trying to establish an additional 4 residency programs by 2030. And so right now our partners are Burrell, who's working on an internal medicine program in Las Cruces. UNM and in PCTC are working on a psychiatry program in Doña Ana and a San Juan psychiatry. They're in a capacity assessment. Really early stages. So we haven't officially counted that as our 5th residency yet, but hoping to soon. San Juan Regional Medical Center, they're in their final year of establishing their program, so they will be open very soon for an internal medicine program with a primary care focus. And then the University of New Mexico is working with Hidalgo Medical Center in Silver City. That program has struggled. It's been struggling to get reestablished since they closed around the pandemic. And so we're hoping with UNM's support and a new approach that we'll be able to reopen that program in the next few years. So that's where we're at with GME, and thanks everyone who works on this program. Appreciate all of your dedication to this. Next slide. All right, another more good news, and we have done a lot of work over the last several years in partnership with the legislature to increase rates for primary care and to really bolster primary care for our Medicaid patients. And so we have had success growing our newly enrolled Medicaid primary care providers. And so that really should be, this continued growth should help with access. But we have added chiropractic coverage, as well as doulas and lactation consultant services, and new access and appointment standards for our MCOs. So we have had over the last few years some primary care access successes, which is great. Next slide. All right, I'm also really excited, if you all hadn't heard already, that we've opened the primary care delivery fund applications for this fiscal year. So it's for the fiscal year 26 through 28 funding cycle. We received $20 million from the legislature to continue this program, and that application opened on July 1st. We've had 2 webinars discussing Rural Healthcare Delivery Fund, how to apply, and some technical assistance around writing a strong budget and work plan. For this funding, the primary focus for the funding is on primary care. And so you can get more information about what that means. We've really used the Primary Care Council's definition of primary care, which includes integrated whole person, person-centered care models. And so we're hoping to get some really great, strong applications for expanding primary care in communities. And so I'm really hoping to work with you all to get the word out, especially to our FQHCs as well, to see if we can't get some innovative, creative, and good projects to help people expand. These dollars can offset operating losses to expand services. And so it really is a net neutral for you to be able to do this expansion work. So it really will set you up for success in offering more services. So feel free to reach out to myself, to me, or you can go to the HCA website, and at the top there's a Rural Healthcare Delivery Fund link. If you go there, you can find all the information about this program. Right, next slide.
Oh, sorry, I don't know what I did. Okay.
All right.
Before I go into the next slide, I just wanted to see if anyone had any other maybe announcements that would be pertinent to this group to open up the space. Anyone have anything? Nope. Okay, and yeah, we'll go right along with our main activity today. So I've been hearing from a lot of folks, especially in the work groups. You know, we've asked you to really relook at the strategic plan and the goals that we have set out for you know, the various goals that we have, and really a lot of our work groups are tied to the 4 goals that we have outlined in the strategic plan. So we thought it would be a good time for us to have space to really have the groups that either are involved in these work groups or just have an interest in a particular goal to just consider kind of, you know, are these goals still relevant? Are there things that we maybe need to, I guess, redirect our focus, or maybe just even change goals a bit? And really, yeah, what to help the work groups, I think, really forage ahead this year, and also considering some of the changes we have coming, where that focus should be. And that also might mean what's missing maybe from those goals. So what we're going to go ahead and do is we're going to break out into 4 rooms by goal. I hope this works. Room 1 will be for goal 1, which is really focused on health equity. And Elisa's going to be in that group to just help facilitate. And we'll ask someone in that group to go ahead and do kind of a report out when we all return back. I'll be in the second room, which is really around investment and payment. Obviously, because I have an interest with overseeing the payment reform project. And then Keenan, which I hope is here, he will be in room 3 for the technology work group. And then Alex, if Alex is here, she'll be in the workforce, but I may have to go ahead and just loop around to each to see that we have representation in each. I might ask one of you to go ahead and do that. At the bottom of the PowerPoint is the strategic plan that you can get online. I'll go ahead and also put that in the chat for everyone so you have access to it. And yeah, we'll see how this goes. Hopefully we won't have any major technological issues. So let me go ahead. Do we have Keenan and Alex?
I'm here.
I'm here too. My
Thanks,
camera
guys.
just lost connection. It's
Thanks.
weird.
Appreciate it. I'm like, I can't see anything once the presentation is up. Okay, we will go ahead and separate rooms. You should be able to select the room you want. So keep in mind which one. Let's see. Go. Okay. Okay, yep, it looks like they're open. I'll go ahead and start renaming them just to remind people, but you can go ahead in your groups if you'd like. get this renamed so people know.
Tristan, I'm not seeing it on my screen.
Oh,
Is
maybe
it-
that's what I have to do. Open rooms.
There we go.
There we go. I'll just start renaming them in case anyone forgot. Investment will be 2. Go ahead and choose whatever room you have interest in.
Would you go over the rooms again?
Yeah. Put up. I've got all of them. Oh, and sorry, I should have mentioned, Maggie, we didn't do the behavioral health integration one only because we don't have a goal yet. So
That's
we're
fine.
just
I
doing
can
the
weigh
other
in.
4.
I can
Yeah.
weigh in on the others.
Of course you
Just
can, yeah.
I can't remember what they were.
Here you go. If you look at the rooms, I went ahead and put the name. So room 1 is equity, 2 is payment and investment, room 3 is technology, and room 4 is workforce.
For some reason, I still don't see the rooms on my screen. I wonder if I'm just not
That's so weird.
in the right view or something, because if other people are getting in.
Yeah, let me see if I can just assign you, Matt.
Yeah, I'll be in 4.
4? Okay, let me see if I can move you
Thank
in
you.
there.
Thank
Let's
you.
see. 4.
I don't see them either. Tristan, this is Aaron Jacob.
You
Trying to get to
don't,
room 2.
that's-
Trying to
That
get to
is
room
so
2.
weird. Okay, you want 2? Okay. Aaron, you're going to 2.
For Elizabeth Olguin, can I have 1, please?
Yes.
Yes.
1.
This is Jessica Osenbruba. Can I have room 1?
Yes. 1.
This is Wendy. I don't remember the rooms. Could you repeat them?
Equity, payment, and investment technology or workforce.
I'll take equity room 1.
Equity? Okay. There we go. See, where are you, Matt? Oh, I don't know why you're not showing up on my thing. It says you cannot access them.
Oh, and you can't see me either, huh?
That's so weird. Do you want to?
Log off and log in, maybe?
Yeah, that's the only
Okay.
thing I can think of.
I'll try that.
Thank you.
Sure.
Okay, let's see if I can do it again. Of course, you're going to be the one that's got a weird. I don't know why I can't assign
Still?
you.
And
Yeah.
on this one, I'm on the Teams app. Maybe if I get on the browser, I'm going to try again.
Okay, that sounds good. Okay. Let's see. Try again. Oh, I can now. Okay, and you said 4?
4.
Okay, you got
Thank
it.
you.
Yeah, of course. Glad we figured it out.
Yes.
I was gonna run out of things, so
All right.
see you soon.
Okay, so you'll just move me in there?
Oh, let's see. Yeah, it should be. Yep. There you go. Okay.
Tristan, could you send me back to room 2 if that's possible? I just kind of
Yeah.
lost connection. Sorry.
Oh, that's weird. Okay. Okay. Should allow you to go back in there. Teams is a little weird. I definitely prefer Zoom. Okay, you should be able to go in there, select it at the top. Thanks, Keenan. Poor Keenan, I asked him, I think yesterday, to help with.
She asked me well before this. I didn't respond to her email until yesterday. It's the truth. But yes, happy to do this.
To be fair, he's Alana's coverage while she's out this week, so he's been busy. Appreciate it. I think the equity group, they're returning shortly. The workforce, they had some very good discussion going apparently, so I think we can give them a little more time, if I wants to take a little break, I think we can, especially since we have one less agenda item today, so go for it, Maggie. Do you guys have someone to report out, Keenan, from your group?
I took notes. I can do it.
Oh, okay. Sounds good. I like your background.
Thank you. There's a template available for you in one of the folders.
Oh, well, I don't want to steal yours. I gotta come up with my own.
No. This came from Heidi. Heidi gave it. Everyone has this one. I didn't make it.
I know.
Rock now.
I need to make my own unique one. Is that like Shiprock or Winter? It's gotta be Shiprock, somewhere around Shiprock.
Somewhere around Shiprock, yeah.
Yeah. Thanks for joining, everyone. The workforce group is still going strong, so we're going to give them a few more minutes because they had some pretty active discussion. So if anyone wants to just take a little break, I think we can do that. We've got a little more wiggle room with one less agenda item today, so feel free to take a bathroom break, water break real quick.
Hi, Wendy. I see your comment in the chat. We did not go back to our work groups. We're waiting for some of the last work group to finish joining us, so they should be here momentarily. In the meantime, I'd like to call out Aaron Jacobs for not joining me in the informational technology one. I thought it was a sure thing. Former CIO would be there, but he's, once I left UNM, he doesn't want to talk to me anymore, I guess.
Couldn't be at two places at once.
Wait, do you know Aaron Jacobs, Keenan?
I do. I used to give him a hard time.
Oh,
All the
good.
time at UNM when I was there, but
Apparently still does.
Okay. Well, I think we're going to get started. The workforce, they're still moving through some stuff, some good stuff, but I think just for time's sake, we'll probably get started and they can filter back in when they are ready. I don't want to stop good discussion. So, okay, so reshare my screen. Let's see. Yeah, man. It's definitely not as good on Teams as it is on Zoom to share your screen. Okay.
Justin, did you want to do just a report out while you're working on getting the screen up? Maybe?
Sure. Yeah. Do you want your group to get started, Elisa?
Sure. If somebody wants to just kind of give a brief overview, just a couple of highlights from our discussion from our group. Maybe Jen or Val, Jennifer or Val.
I could do it for the group 3 one. Oh, are we talking about from group 1? Sorry, I thought you were talking about Jennifer Phillips. Sorry.
We'll get to you, Keenan. Patience. I know you're just so excited. So excited.
He's got a lot to report.
Jennifer, do you want to give a very high level from our group?
Yeah, sure. I can. Am I on? Yes, I'm unmute. So, we're in a challenging space, right? As we talk about health equity. So we were reviewing objectives. The group is trying to work on that, but I think it's challenging because this particular arena is a moving target right now. So there has been some hesitancy, I would say, over the past few months, trying to understand how to update those objectives. I will say that some of what we talked about was it's going to be incredibly important as we reflect upon what Matt Probst was saying about the days before the Affordable Care Act, and if we're sort of moving backwards, or so it seems, in this arena, that we really have to figure out really concrete and structured ways to hold ourselves accountable to health equity, because there's sort of less incentives to do so. So therefore, we talked a lot about how data is still incredibly important, and that we're going to really hold ourselves accountable to having dashboards that make sure that we don't let health equity slip off the table, as important tools as part of the objectives for the health equity group. And so how to empower other groups then to have access to these tools, whatever space they're in, from workforce development to others. We had, we talked a little bit, or at least I sort of was talking a bit about, tools that one could apply would be a really structured health equity lens to provide others that includes, prompts that even reminds us to include community voice in decisions that are made, and felt that that might be a worthy contribution out of this group. But we also talked about the need that there's so much to be done in this space, and so the desire to just to really start wanting to do implementation work in all sorts of upstream areas, from food insecurity to, housing to everything else that's so much related to how primary care ultimately is able to succeed is important as well. So, a lot of competing tensions here. So I will ask the other members in the group to join in. Thanks.
Thanks, Jennifer. Appreciate it. Glad we have you in New Mexico. Meet you. Anyone have any feedback or thoughts?
Unfortunately, I was too busy talking in the other group to hear everything that Jennifer had to say. But the last little piece of what Jennifer said, I think the first thing that came to my mind was structural competency and really understanding all of the structural issues that cause inequity and disparity. And I think that's a politically safe way of teaching and working on equity without, I hate to say that without mentioning disparity, but really it's an upstream approach and it's a global upstream approach. And so I wonder if we could function or work on really structural competency and thinking about the upstream causes of illness and disease and how we intervene. And I'd be happy to talk to people about that. And NMSU has developed a really nice course on that that's free, that is online, which is really cool because I think once people are able to adequately articulate the structures and the theory, then you can take actionable steps around that.
Is that online course? Can anyone do that? I was just going to ask.
Anyone can do it. It's free. It's a certificate course through NMSU. It was developed by I don't know who it was developed by. Mary Alice Scott was part of it, but I can't remember. I think it was the Doña Ana Wellness Institute that was actually, I know it was the Doña Ana Wellness Institute, which is the county collaborative in Doña Ana County that got that up and running.
Awesome. If you have the link by chance, if you wouldn't mind sharing it in the chat, John, I think people might be interested.
Is Jamie Michael on?
I'm looking for it.
Okay.
I'll look for it. Yeah.
All right.
I was reading your mind.
Thank you. I think that would be great to share, and it's and it can lead us into more actionable steps. Yeah.
I'll also share the free SDOH certificate that we have through my office at UNM, Office for Community Health. I think those are great tools that I wish everybody would be certified, not just our CHWs, but all our entire workforce, especially the administrators. The providers are easy. We get it.
Yeah, it's true. Need everyone, right?
Yes.
Anyone else? I think I interrupted you, Jen, so if you wanted to. Or anyone else? Any other thoughts? Regarding goal 1. Okay. And I think we'll do room 2, which was mine for the payment model and strategies, which the goal is essentially all around, right? Our current project that I'm working on, the primary care payment reform. So our conversation was a little bit different, but I'll let Aaron just kind of summarize what we heard in that group.
Sure. I think in summary, it was that it's important. It's moving forward slowly, or maybe better said, deliberately. But in the face of a lot of concerns for the unknown in terms of financials, and if that's going to still be part of this or not. I think it's a huge step backwards if the state can't remain committed to this transformation in primary care, but I'm concerned. And I think that's sort of what the group's general consensus was.
Yeah.
But that, as it is, it's moving forward.
Yeah.
It's been a slow process, a lot of input, a lot of feedback, some tweaks. But I think the concern is that it's at risk.
Yeah. Thanks, Aaron. Anyone have any feedback or thoughts on that? Or anything to add if you weren't able to join us? Sorry, you guys will get used to it. I do really good long pauses. I trained at UNM, so they taught us how to pause long for those patients.
It's a little awkward, Tristan. I find it a little awkward, actually.
Yeah, I know it makes a lot of people uncomfortable. So
just kidding. You're very good at it. You're very good at it.
A++ for my pausing. Okay. Of course, I'm always dying to hear what people are thinking about payment form because that's taking a lot of my time, but we can move on if no one has anything. Keenan, I think you were going to report out for the technology improvements group.
Yes, thank you. We were a small but mighty group, so a lot of great discussions. So to kind of address your questions you posted, definitely still think this should still be one of the goals. And we had some interesting discussions about different places we're seeing more technology being used. They talked about a pilot going on at UNM for a AI note generation tool. I've heard from the several providers, not just Dr. Phillips when she was presenting that it's been very transformative in their ability to provide care, and it definitely decreases burden. And there is some it's still a pilot, and they have to see about buying the licenses and scaling it to its full operational, as well as being safe and secure with AI, which was a valid point being brought up. Maggie talked about some of the integration with behavioral health and some of the data dashboards that are currently being developed between HMA and this work group. And I think that ties nicely to some of the things Jennifer was talking about how do we use data, how do we make sure that equity is included in our dashboards. And so how do we create and make sure we're having good information coming in if that's going to be our platform we use. I did raise a question about how do we know what our current IT infrastructure is for the state. It's great that UNM is able to implement this AI system, but we also know that there's plenty of primary care providers that aren't even feeding information into the HIE, which I don't think is a dynamic solution, but that's just where we are. So where do we exist across the horizon for our different providers in different areas? And Maggie had actually said that there was a telehealth group advisory study looking at different implementations of telehealth pieces, which she said she would send to us, which I think would be something worth. Maybe the PCC has looked at it. I'm just on the outside, but it might be something worth seeing to see where everyone is. And then just a couple of call outs with this.
I'll follow up on that and Tristan, and put you in touch with Stetson Berg, who is the chair of our committee.
Sounds good. Thanks, Maggie.
I'm sorry to interrupt you. Go ahead.
No worries. Thank you for closing the loop there. Just a couple of call outs that aren't exactly within this role, but something that was brought up is if we're using information technology or telehealth more, how do we need to work with interstate compacts to allow for an expansion of care for New Mexicans? How does that work with liability laws that currently exist? Also, is there ability to mandate interoperability? The EMR system is really two big players these days. If you get those two to talk to each other, you're pretty much going to bring everybody else on board. But Is that something that's even feasible within the state? And if I forgot anything, please let me know, group.
Nope. I think you captured it well, Keenan. Sounds like you guys were busy in there. Do anyone have any thoughts or feedback about any of that? Okay, I think we'll go to group 4 then, which was goal number 4, which was about workforce. I'm not sure who was going to report out on that, so I'll just let whoever going to do the report out get going.
Dr. Andazola is going to report out. I just want to say, I dropped into the chat some of the consolidated updates to the strategic plan objectives that they came to. Honestly, great discussion that probably could have gone on for an hour at least. So I had to drag them back and stop them in their tracks. So this is as far as we got.
Thanks,
Yes.
Alex.
Yeah, thank you, Alex. It was a great group, and we did have lots of conversation. I think the very first thing was we thought is as part of PCC, how important is workforce and the discussions around that, and should we continue the discussions around that as part of our strategic plan? And it was unanimous that absolutely workforce is a key component of primary care council, and we need to continue to focus and work on strategies around that. We did look at our previous strategic plan and our workforce objectives around that. And we noticed that a lot of the workforce objectives were about gathering data that's, robust and provides us with enough information for actionable items. However, we did notice that there are also redundancies in the system, that data is being collected by other groups throughout the state, even though the data may not be perfect and there's questions about accuracy of some of the data. The data overall tells a story that's actionable, and we can utilize that. And so we really wanted to think about making sure that we collaborate with the current ongoing data and have representation with the workforce data group. Matt knows more about that. That's the big one, and really have PCC as represented on that group, so communication can go back and forth between the two organizations. We also talked about return on investments and how are we measuring that. So if we do workforce initiatives to train and retain physicians for the state, how are we measuring our retention? How are we measuring our outcomes? And we talked about measuring that at the medical school level, measuring it at the residency level, and that would include, of course, other programs, nursing programs, PA programs, et cetera, and the retention activities of those, but also maybe looking at retention of physicians in FQHCs and as well as the state in general. And what kind of activities are we doing with that? How do we collect that data, and what's that look like? The other thought I think was really important was doing something actionable. Instead of just looking at data, what can we do? What can we do? We know there's been some recent reports out, not just the workforce committee, but also Think New Mexico that has a whole pamphlet on workforce retention ideas. And we thought there was some low-hanging fruit there that we could attack. And one of them specifically was addressing loan repayment and modernizing the loan repayment system in the state of New Mexico to increase the funding to $250,000 instead of $75,000, and making it longer, because there's really good data that says that if you can keep people in the state for 3 to 5 years, they're more likely to stay in the state. Any less than that, the turnover is higher. And so really working at looking at other states, what they're doing, and working with our legislature to increase that. And I know that's on the governor's agenda, and I know the legislature has been very supportive of that. So very actionable items. And then other actionable items we were thinking about is, and I want to talk to the committee about this. We're the primary care council. We know, and this is an echo chamber, and we're the choir, and we're preaching to each other. But the thing is we know that primary care makes the difference, right? We know that primary care improves health, reduces cost, increases socioeconomic status within communities. We know that. There's mountains of data on that. But we don't necessarily see that reflected in our graduates, right? Our graduates should be really choosing primary care. Our students entering and entering their learning opportunities should be focusing on primary care. And what do we do around that? We talked about in our subcommittee yesterday about creating a marketing program around that, where we're talking to medical students, we're talking to high school students, we're talking to the community at large about the value of primary care. That's stated over and over again, how important that is and why it's important and what that looks like. And then, I think people should be able to understand that versus we don't know, we don't have enough sub specialists to treat my sub specialty disease. And so that was another strategy that we talked about. That includes pipeline and pathway development as part of that. And I think that goes hand in hand with a lot of the work that Matt has done with his SEMIAs. So I think that was the meat and bones of some of our breakout session. I was going to ask any other members of the group if they had anything to add. Matt?
I'll just add that you're all invited to Vegas. Come, I'll take you to lunch on LHHS in the Highland Student Ballroom, July 21st through 23rd. We will have a table about our residencies. So, this is, I'm giving this a little early, draft agendas we'll post on the websites. But so there will be specifically about residencies, but there's also about this Semillas de Salud and this effort for upstream initiatives. That's the kind of the root of, regardless of what branch you end off on, back to our ancestral knowledge, that if it's regardless of what health career, that it's all that common root in the pipeline or the funnel. So yeah, so anyway, there'll be more on that in a specific project that was funded to Department of Health already. And so I'm excited to let you guys know, and that's clinical rotations in school-based health centers, linking off of our hub and spoke school-based health center expansion program. And so, yeah, please come, and I will definitely share the links to everything on the LHHS page once those documents post.
Thanks, Matt. I'm gonna try and go. I don't know if I can or not, but it's been a while. That's a lot. Anyone? Thoughts? Comments?
In discussion, and I think we can do this, Tristan, in subcommittee work, is really look back at the what do we call it, strategic plan, and make those adjustments. And I think really the group is really leaning towards actionable items, and trying to figure out what other steps we can take to do that. So I think, but that can be done in subgroup work.
Yeah, sounds good, John. To be fair to everyone, the workforce work group or committee John's referring to met yesterday. So they already had some really good momentum with these ideas. So anyone else have any thoughts? before we move on to our break? Hey. Right,
I
so I
just
think, oh, go ahead.
Oh, sorry, it's Jennifer. I just added something in the chat. You know, as I think about the enthusiasm out of what you're doing imminently here, like uh, instead of just focusing on just like GME, as we think about more um, pathway development and including more members, if we're putting the work into developing these opportunities, there's a beautiful program that was developed by Renee Critchlow originally in Minneapolis called The Ladders. But it's a peer mentorship program. It engages people, I think even as early as age 7, she has seen this get involved. And, you know, I'd be happy to talk to you more about it at some other time, but it's a great program. And you just start, it's, you know, like the middle schoolers are mentoring the elementary school kids and the high schoolers are mentoring and it goes up the ladder until you finally have like physicians like John Andazola or you, Matt, you know, sort of then mentoring, you know, residents, and then medical students, et cetera, you know, but it was, it's not a particularly costly intervention, wildly successful.
It's a pyramid scheme.
And, you know, people were
Yeah.
throwing money at this program.
Yeah.
But anyway,
It's a
it's a sweet
pyramid scheme.
model.
I learned how to do that, selling prepaid legal insurance to put myself through PA school. But so, yeah, so I talk about the funnel and we talk about the GME and everything on the end, little funnel, and hopefully they come out and they stay in New Mexico. Semilla de Salud is talking about the broad providing children opportunity, childhood opportunity index data at the top of the funnel. And then on the next slide, I flip the funnel upside down and it's a pyramid scheme because the very few of us, and including those of us on this call that can serve as preceptors, there's just not enough of us. So I precept that student, and while they're here, they're working with the Dreammakers Health Career Club, and those Health Career Club students are peer health educators on their campuses and providing presentations to the middle school students, and the middle school students are providing those peer health education presentations to the elementary school, and the elementary schools, you know, making Valentine's Day cards for the nursing home. Everybody serves, right? And so that's the idea, and it's how we're built, again, ancestrally, back to our resiliency. And so, yeah, it just fits right in. But please do link me because I hadn't heard this is happening somewhere else. And if across the country we can kind of, you know, show those efforts together, that's just even stronger.
Absolutely. I want to join in. I just want to thank you, Jennifer, because the near peer mentoring is really huge. And near peers are way more valuable than me talking to high school kids because they think I'm an old man. So I think having that near peer structure is brilliant, and really, really could be developed to help us train and retain people for our futures. Absolutely.
You're going to see it in the presentation at LHS, but they're also getting certified as community health workers. They're getting all their coursework done in health career classrooms in high school. Now they can't take the test till they're 18. But that means that these students now, when they need their, you know, side job to put them through school, they don't have to sell prepaid legal insurance. They can be working, you know, as a CHW, as an EMT. We have several, you know, phlebotomy, several health career pipeline directions they can go on, pathways. I love that word. But yeah, that's the idea. So they're working right away by force multiplying us in a way, John, that, you know, their peers can connect better. I'm just that old guy now. You know, but and then linking them to the correct care that the peer health person can't do at the school-based health center, you know, behavioral health and primary care needs, right? And so, yeah, that's exactly the idea. With limited resources, we can force multiply it.
Awesome. Thanks, guys. It's a great discussion. So we're gonna go ahead and go to our break. I know this says 11:40, but I'm gonna say, let's say 11:50 for folks to come back. Just so we have a good break before Jackie is gonna talk about Senate Bill 3 with us. So go ahead and take a break if you want. You can turn your screens off if you like. We'll see you back at 11:50. Jackie, do I need to give you access to share? I think it allows anyone to share. Can you check?
I think it auto allows. Zoom,
Okay.
I think, is the one that's,
You have to give permission.
yeah.
Yeah, sounds good.
Let me see if I can just share while we wait for people to
Yeah, that'd be great. Thanks, Jackie.
come back.
I like your background too. It's a very nice looking place.
It's just taken from the ski basin.
Really? Wow.
That's what it said
Yeah.
when yeah, looks like I could share.
Oh, awesome. Okay.
Can you see it?
Yep, I can
Okay.
see. Yeah.
Good.
So people, I put it in the chat, but folks can just start turning their camera on so I know who's back. And then we can get started in a couple minutes. Thanks, guys.
I'm back, but I have another meeting at noon, so.
Okay, sorry.
But thank you for letting me attend. I appreciate it.
Thanks, Michael. Okay, thanks, Janice. Glad you're able to make it. People can start turning their cameras on, just so I know we've got the majority here. And then we'll have Jackie share. And a bill 3. Okay. All right. Well, I'd say we can go ahead and get started if you want, Jackie.
Hold on.
No problem. Yes, I don't love the sharing, starting a presentation, all that. It's very weird in Teams. It's not easy to navigate.
It always goes to that notes one. I don't know why.
Yeah, it's like you have to share the screen that has the actual presentation on it.
Oh, okay.
Yeah.
That's right. So we got to do the.
It's like you start the presentation first, and then if you can pull your Teams up again, just make sure you select your correct screen that's just got the presentation.
Yeah. But
I know.
I can't come back to the, hold on.
Yeah.
Let's see.
I know, it's like the Teams disappears. I had to just go down below and reopen it.
It's doing this, but how do I get to the big one?
I think if you hit share again, you can switch your screen at the top. Elisa's better at this. I don't know, Elisa, if you have any other guidance.
Oh, maybe. Okay. Sorry,
Got it.
guys.
No, you're
Dang
same
it.
issue
No, I
this morning.
closed it. I had this all queued up. Hold on just a second.
Don't worry. I'm like, this is why I like Zoom so much. Like, I'll have to tell Lisa, maybe we'll use her Zoom account next time. I don't have one, but Zoom's a little easier.
Are you guys still seeing a shared screen?
Yes. We're seeing Tristan's.
Oh, I think it is Jackie's.
Like, can you see this, or is it too small?
We can see a full slide. It doesn't look like it's in presentation mode, but it does look like it's just the slide
Now
that
it's
you're
worse.
on. Yeah.
Hold on.
Okay.
Like, is that okay for everyone? Like, is it gonna, because now I can't find.
There we go.
Now I can't find, is it too small?
No, it fills my whole screen, and it's got your first slide with Christy's name on it.
All right. Well,
Yeah.
then we'll just continue.
Okay.
All right. Hello, everybody. So I'm Jackie Nielsen. I am the Deputy Director of Policy at the Behavioral Health Services Division here at the Healthcare Authority. This is my second meeting with you all. I'm here to help, help you all and help my behavioral health related group to, try to integrate some behavioral health topics into your and to align with your already established goals. And so I think there's a topic on the agenda to see how we can help do that. I'm here today to talk about the Behavioral Health Reform and Investment Act. This act was passed at the 2025 legislative session. It's also known as Senate Bill 3. So if you all Google New Mexico and Senate Bill 3, you will see the whole bill in its entirety, but I'm going to give you a brief overview of the bill. So I'm going to skip the land acknowledgement as Tristan already showed it to you all at the beginning of the meeting. But I will go over the mission, vision, goals of the Healthcare Authority. So the mission is that we ensure New Mexicans attain their highest level of health by providing whole person, cost-effective, accessible, and high-quality health care and safety net services. And that's the theme of Senate Bill 3. It's the overarching theme of Senate Bill 3. The vision is every New Mexican has access to affordable healthcare coverage through a coordinated and seamless healthcare system. I mean, that's all what we're trying to do here in our council today. Oh, you don't see the next slide with the mission, vision, and goals?
No, Jackie, it's still on the land acknowledgement slide, at least for me.
I see the mission, vision, and goals. So
Me too.
your screen
Okay.
freezing.
Oh, maybe it's just a little slow on your side, Jamie.
Maybe I see it now. Sorry.
Okay, that's okay. And the goals of the Healthcare Authority are to improve, address, support, and provide. To improve, we leverage purchasing power and partnerships to create innovative policies and models of comprehensive healthcare coverage and improve the health and well-being of New Mexicans and the workforce. That's a mouthful. To address services, we achieve health equity by addressing poverty, discrimination, and lack of resources, building a New Mexico where everyone thrives. That aligns with the council's goals as well. And so does leveraging purchasing power. Support, build the best team in state government by supporting employees, continuous growth and wellness. And implement innovative technology, data-driven decision-making, and provide unparalleled convenient access to services and information. So the next slide is the overview. Everyone see the overview? Good. So today I'm going to go over just a summary of Senate Bill 3, who the responsible agencies are for implementing Senate Bill 3, the objectives and goals, the timelines for Senate Bill 3, and the current status of where we're at since it was passed. So Senate Bill 3, I'm just going to refer to it as Senate Bill 3 because saying Behavioral Health Reform and Investment Act is just too long to say. I'll interchange probably with SB 3 from time to time. So SB 3 establishes the Behavioral Health Reform and Investment Act. This act, it takes a regional approach to behavioral health care. If those of you that have been in behavioral health or know about behavioral health, this is not new to New Mexico. There was a regional approach some years back in New Mexico for behavioral health. So this revisits that. It doesn't revisit it in its entirety, but it takes some of the elements of that approach that we had some years back. It involves all three branches of state government. It has some companion bills that go with it, Senate Bill 1 and House Bill 2. I'll talk a little bit about House Bill 2 first. House Bill 2 addresses the immediate financial component to help support SB3. So House Bill 2 was where money's appropriated to the Healthcare Authority. It's around $62 million, but it is not necessarily appropriated like other funding has been appropriated to the HCA in the past. House Bill 2 will appropriate funds to each region, and we'll get to that in a little bit through the slides. It funds the regions for the next 4 years, and then Senate Bill 1 is an investment bill. So that actually comes from investments from different parts, from different investment streams in New Mexico, and that's supposed to sustain funding after the 4 years is up, after the initial investments were made, after the initial funding was appropriated through House Bill 2. Hope that makes sense to all of you not in state government and not familiar with all the components of how things operate, but I can take questions at the end. So in Senate Bill 3, each region will identify up to 5 behavioral health priorities and request funding to implement the 4-year plan. And we'll get to the regions in a bit. And it requires behavioral health stakeholders such as yourselves to work together to support the expansion of behavioral health services in New Mexico. And the bill was signed on February 27th, 2025, during the legislative session. So the responsible agencies that are associated with the bills are us, the Healthcare Authority, primarily the Behavioral Health Services Division and the Medical Assistance Division will be working to implement the bill. The Administrative Office of the Courts, the Legislative Finance Committee, and the Behavioral Health Executive Committee. The Behavioral Health Executive Committee has components of all of the state agencies that I mentioned above, and we'll talk about that. So the objectives and goals. So the Behavioral Health Executive Committee, that's what we talked about in the prior slide. It consists of the Secretary of the HCA, the Director of the Behavioral Health Services Division, the Director of the Medical Assistance Division, the Director of the Administrative Office of the Courts, and 3 behavioral health experts. The 3 behavioral health experts appointed by the Administrative Office of the Courts are Dr. Stacy Cox of Silver City. She is the CEO for the Center of Health Innovation, and, and that is embedded in the New Mexico Public Health Institute. Dr. Violet Cloud, she is located in Albuquerque, and she is a Senior Project Associate with the Policy Research Associates Incorporated. And the former state senator Jerry Ortiz-Pino of Albuquerque, and some of you might be familiar with him. He was a very valued advocate of behavioral health services here in New Mexico for a long time, many years on the legislature, and he was a strong voice when it came to behavioral health. The Administrative Office of the Courts, they selected these in the bill. They were responsible for selecting these behavioral health experts, and they did that, and they chose these 3 people. The key focus of the committee will to meet quarterly through public meetings. They had their first meeting now in June, and they'll report to the LFC, the Legislative Finance Committee, quarterly on the implementation of the regional plan and the bill itself. And the key goals for the committee are to designate the behavioral health regions, review and approve the regional plans, establish funding strategies, and monitor and track deliverables. And that just means is the bill being carried out the way it was supposed to? So a regional plan is developed collaboratively by the behavioral health stakeholders. So I'm just going to skip ahead a little bit. At the executive committee in June, the regional plans were introduced by the administrative office of the courts. In Senate Bill 3, that was their responsibility, were to establish the regional plan, the regions. The regions, they decided to establish the regions in a way that aligns with each district court. So there are 13 judicial district courts. There are 13 regions. And so each region, this is very complicated. Each region is approved by the executive committee, and they did that at the meeting now in June, or back in June. We're already in July. Each region will identify up to 5 state-funded priorities, and so that's where your voice and people in the behavioral health field, providers, advocates, people with lived experience, consumers of Medicaid services, recipients of Medicaid services, people that don't receive Medicaid services, private sector, private insurance, all of these different stakeholders will meet to identify what the priorities of each region should and will be. And I already said this, on June 24th, the Behavioral Health Executive Committee voted to adopt the 13 behavioral health regions. So that did happen. There are 13 behavioral health regions now. Each region will go through what's called sequential intercept mapping. It is a tool that's utilized as a cross-system approach to help communities identify gaps in resources. Some of this has already been done in some of the New Mexico counties. The Administrative Office of the Courts is working with different stakeholders and experts to develop this sequential intercept mapping. The Behavioral Health Services Division is responsible for establishing the behavioral health standards, service standards. So we've done this. That was due June 1st, and we've done this already. We aligned the service standards, what is in the state plan, Medicaid state plan, what we aligned with ASAM level of care. We aligned with service delivery through the New Mexico Administrative Code and what that means. We put it all together in a comprehensive, complete manner, and we submitted that to the Administrative Office of the Courts so that they can distribute it to each region. The LFC and the HCA, the Legislative Finance Committee and the Healthcare Authority, we also work together to develop evaluation guidelines for each region. And when I say each region and you're like, well, where's the region and who has this information? That still needs to happen. So the first region meetings have not yet happened, and that'll be dispersed and disseminated when that happens. But it is done as of June 1st. The behavioral service standards are complete and the evaluation guidelines for each regions are complete. The goal for this is to ensure best practice and make sure that services are delivered. So I talked a little bit about this on the first slide. House Bill 2 will be managed by the Behavioral Health Services Division. House Bill 2 is, like I said, it's the immediate funding needs for the regions. This is the 4-year funding strategy. The funds will be used to address the priorities and funding gaps set by each region. It will be equitable and shared between each region's identified priorities. Again, 4 years in length. It will be used to cover uninsured and indigent populations because we want the regions to utilize Medicaid as well as other funding sources as well. And 5% can be used for emergencies that may adversely impact behavioral health services. So it would be for those emergent needs that they need to address pretty promptly right away. Regions can also request to repurpose unused balances, and we're setting up how all of this will operate. We're developing proposal guidelines, funding guidelines. This is all in the works right now, even as we speak. And the goal of the investments is to provide funding for regional priorities with input from local agencies.
Jackie, this is Maggie. Can you take a question?
Let me do the questions at the end because there's a lot of slides. Yeah, there's not a lot, but there's 20. Credentialing. So we've heard you. This came up at the committee meeting. The Healthcare Authority, the Legislative Finance Committee, the Legislative Health and Human Services Committee. We all work together to establish a universal credentialing system. This is the MCO credentialing system that you are probably familiar with, whether you're a behavioral health provider or a physical health provider. And so we'll be working with mostly Medical Assistance Division, who has oversight of the managed care organizations, to set up universal credentialing systems so that it makes things easier for both physical and behavioral health providers to be credentialed by the MCOs. I see your hand, Elisa. Did you want to say something real quick? Sure.
I didn't want to interrupt, but I know we have another agenda item. And I think we had planned to start that at noon. So just giving a heads up that we may want to do another slide or two, but then have you come back, Jackie, so that we have time for Roberto as well. Tristan, does that sound okay with you?
I think we can stop here, right here, and then after that, it's kind of breaks to goals and objectives, and then we can come back maybe at another time. That's fine.
Sure. Do you want to take a couple of questions then, and then we can have you come back and talk more about it? I just want to make sure that you all have time for Roberto's presentation too. Thanks so much.
Yeah, we can take questions, and then we can come back either later or at another time. That sounds great. It's very complicated, Senate Bill 3. So any questions? I guess Maggie.
Yes, thank you. You said as you were talking about the resources being divided up between the regions, I heard you say that they would be equitably divided. I think that was the term you used. The region, I don't know what number it is, but the 2nd Judicial District, which is in Albuquerque, has a huge concentration of providers. There are many, many, many more providers in that area than there are in the other outlying areas. So I'm just wondering if you have had a discussion or a plan yet about how to balance the intensity and the population in those areas.
Yes,
or
we are
still in the works.
Yeah, it's still in the works. We are talking about that, and it's not anything it's not a secret, but it's not anything I can report on right now. But yes, we are talking about that. All of that is taken into consideration where there's going to be larger districts than others. And there's going to be the ability for, places like Albuquerque and those the counties that fall, I think Albuquerque, Bernalillo, it's its own district, I think. Judicial District Court. And so, they'll have much better capacity and ability to carry out funding and to meet the service gaps than others, like in the most rural parts of the state. So yes, we'll have to look at that. And it's up to the regions to decide how to demonstrate their capacity and their ability to carry out the funding and to distribute it to the providers in the area and to bring in new providers into their area. This is more about capacity building than funding additional funding providers that are already in place, so that in the rural areas, like Matt talked about, it'll be an opportunity to build that capacity in those areas a little bit better.
Thank you.
Any other? Matt?
I'll just point out, and I don't know that this has been discussed, but the evolution of the Rural Healthcare Delivery Fund and then this coming climate of federal cuts. To me, when I'm speaking as Director of Rural Engagement to administrators and executives from existing agencies, sometimes, and especially in round 2, and I hope it changes in round 3, but it feels like they start thinking of this as a sustainability mechanism for things that are already existing. And it's like, will this cover our operational costs? Will this cover, I know we dealt with this a lot, we need a new facility, right? Because our old facility, we need a new one. The whole point of this is expanding access to care and moving the dial, very much like Rural Healthcare Delivery Fund, right? It's about, we're here, whatever that is, that depending on what data you look at, we know we're very, very short, right? We're far away from our goal of saying every New Mexican has timely access to care. And the point of these funds, including this huge breakthrough, is to say we went from here to here, right? And be able to measure that in ROI. It's not about, I have this program and sustain it. However, I understand when when there's this federal climate and we're trying to do this at a state level in a federal climate, that there's, you're just trying to keep the foundation. How could you build another level if the foundation's at risk of cracking, or your Ruidoso horrible thing and crises, and next thing you know, your house is going down, the mountain in a flood. I just, that's an interesting balance act in this time. And I know when we were planning all of these things, we didn't necessarily foresee this federal climate. So I'm going to be interested to watch. It's not really a question, but how you guys navigate, this storm.
Thanks, Matt. That's a really good point. Thank you.
Just as an FYI, just so you'll know, we broke down all of our member agencies. We have 69 member agencies, and we got a breakout of where they're serving. So we have quite a few organizations that may be housed in Albuquerque or Santa Fe, but actually provide services in the rural communities. And so we've had some discussion about do those, how do we count those? How do we track those? So we have some pretty good information about that, just as an FYI.
Thanks, Maggie.
Jackie, I don't know if you saw Janice's comment. She was asking a little bit more about the sequential intercept mapping, just a little more on what it is.
Yeah, sequential intercept mapping, it's a tool. It's a very detailed, and this is what I know, it's a very detailed tool to identify what the gaps are in certain areas. It's done through interviews, data collection, and it incorporates people within those areas to contribute to identify what those gaps are. Maybe we might be able to have more of a subject matter expert, just give a overview of that, because I think it also can be it's able to identify people in certain areas of need. So if you're somebody that needs services, it identifies where you fall in that sequential intercept, like where and what kinds of services can be identified for you. Oh, and Jamie has her hand up and she might have a better explanation of that.
We've done two workshops around the sequential intercept model, and it's similar to what Jackie said. You see my giant poster back here? So each one of those different colors represents a place within the criminal justice system that you can divert someone or intercept them out of the criminal justice system and move them from the criminal justice system into the behavioral health system. So it starts persons having a crisis. Can we address the crisis? If not, they dial 911. Can we meet their needs at 911? If not, police dispatch. And then it goes all the way through courts, corrections, and release from detention or prison. And at each of those places, because people move through that system in a very sequential process, and at each of those places, how do you divert them out? And we do a good job of creating, in Doña Ana County, we do a good job of creating policies and pathways to divert people out. But then you need the healthcare system to receive them when you've diverted them out. So the hope is that these funds will help create those services in the community so people can move into the services. And I put a link in the chat that might help.
Thanks, Jamie. Oliver?
Oh, I had to step out for a meeting and my hand was up from our meeting, so I just lowered it. My apologies.
No, you have to ask a question now.
Thanks, Jackie. Very much appreciate you. I'm going to drop again. I had dropped a survey in. Jackie had alluded to it, but we ended up doing a survey around some questions on behavioral health integration and some other stuff on MAT. If you guys can do it now or at the end of the meeting, greatly appreciate it. The new work group, as some people remember, we started a behavioral health integration work group, and so they wanted to get some thoughts and ideas on what people define as integration. But if people don't have any questions, I think I'll pass it to Roberto. And now we can talk about closed loop referral.
Hi everyone, thanks so much for inviting us to present. And just let me check first. Can you guys hear me well? And okay, great. Let me just share my screen for a second. Can you see my screen?
Yeah.
Awesome. So my name is Roberto Martinez. I'm serving as program manager for the statewide closed loop referral system. And before I jump into presentation mode, maybe perhaps if I could ask, and you can either give me a thumbs up, one of those on screen like mine here, or you can do a digital one and just click thumbs up if you have heard about what closed loop referral systems are in the past. Maybe not just this statewide, but just in general, do you know what closed loop referral systems are? And I see Matt's thumbs up. Awesome. I'm seeing some thumbs up here as well. Great. And I see some that are not raising their thumbs. And I just asking so I know how much to share in terms of definitions and concepts with all of you. But my overall goal here today is to share a brief update on where are we at with the development and the deployment of a statewide closed loop referral system. That's first thing, just update you. The second is invite you to join these efforts, and I would say in about 6 months. Once the system is ready, I think that's where healthcare system is going to start jumping in more into the picture. I think it doesn't mean that we don't start talking about it now, but I'm suggesting that from now in 6 months, we're going to start building and connecting the network of community-based organizations that need to be in the platform so that there is actually someone to refer to. Else, we are just doing a Google search. We need to have community-based organizations there, and that's going to take us about 6 months. You'll see what I mean. So my second goal, as I reiterated, is to invite you to participate in ensuring that primary care practices are engaged and involved in this process. And I think that there are 2 ways in which we can do this. One is by as we move on forward in the next PCC meetings toward the maybe 3rd or 4th quarter of the year, actually 4th quarter of the year, perhaps receive some feedback from all of you as we present to you our ideas as to how are we planning to engage some primary care providers or all primary care providers across the state. So those are my 2 goals. So let me move forward with these slides. And to many of you who are either physicians or work at a clinic and know the difficulties that exist when you're trying to, you see a patient comes to you, a patient has so many other needs besides the actual clinical needs, and then you refer them to those needs. But typically what's happening right now in New Mexico is we refer them by giving them a little piece of paper. Here, go or call this number, go talk to these people, right? And the reality is that people who find themselves in difficult social circumstances, it's actually hard to reach out, right? If you have a behavioral health issue and now you need to reach out for housing, if you need to reach out for transportation, it's difficult and it's time consuming, and it's actually sometimes very hard to identify where. So in order to solve that problem, that's where the closed loop referral system as an ecosystem where we all can connect with each other through a shared platform and a shared language comes to mind. So where we are at the moment, and this is the implementation roadmap. We are currently at configuring the platform, which is number 3. What that means is that if, and let me actually ask the same to all of you, do you know and have you been to Yes New Mexico? That's what we call internally to HCA, the unified portal, but essentially a way that New Mexicans can apply it for many of the services that organizations in the state organizations state agencies are providing to individuals, like Medicaid. You can enroll through there or at least submit normal. Have you seen that Yes New Mexico before? Give me a thumbs up, or either virtually or with your hands. Awesome. So Yes New Mexico, it's an initiative that was already started by HCA and HHS 2020 agencies a while ago now. And the closed loop referral system is going to be attached to it. And that's where the brand comes from as Yes New Mexico Connect. It is actually live now. So if you go to the Yes New Mexico site, you would see that there is a board for Yes New Mexico Connect for the piece of like self-referral, self-navigation particularly. But what that allows us is what we're calling the MVP under number 3, that second bullet point, branding and MVP go live. That allows us to now start like ensuring that community-based organizations are building the networks. So over the end of the summer and probably even earlier than that, we're going to start doing this effort of building the network, number 4 here. What that means is we're going to be reaching out to community-based organizations so that they can do a few things. One is that they can understand how to take ownership of the data of their services in the platform. Meaning, if I'm a food bank, I'm going to share my hours of operation, my location, and my type of services that I'm providing, et cetera, and make sure that that's accurate so that people can find accurate information. So that's one skill we're going to be training organizations, community-based organizations in particularly. And then the other one is like what I call like switching the lights on. Depending on their capacity, organizations are going to be able to start either sending or receiving referrals directly through the platform, right? Like, and I think that depends on the size of the organization, whether do they have staff that actually can do that or not. And others may decide to, instead of like switching that on, stay as, well, call me or contact me in this way, like in that way, right? But so from sometime at the end of the summer to the end of the year, that's where our focus is going to be, ensuring that we train community-based organizations on how to use the platform. We are going to have monthly meetings, 2 monthly meetings of the one-on-one, how to train, how to do this, the one-on-one closed loop referral piece. And then one monthly meeting webinar series of the 102s, which is like going into the referral piece. And office hours, I think we've destined like about 5 hours a week for office hours for any organization that needs kind of one-on-one as opposed to a webinar, which is hard when you have a lot of like people in a webinar. In addition to that, we're actually working so that there are going to be some self-paced materials so that individuals and organizations that are more technologically advanced or have more capacity can do it on their own as well. Hopefully, we're going to be working with the managed care organizations to do this onboarding together, which will help us and increase like the capacity of reaching out to like community-based organizations. So once we get to those 6 months that I'm talking about of like trying to build a network, ensure that as many organizations as possible are using and onboarded in the network, then we're going to start like more focused, like start working with the healthcare providers. We don't want to go now to healthcare providers and just ask you participate, and then you're going to say, okay, great, I'm going to assign my staff, I'm going to train my staff how to do this, but also they're going to refer, and they're going to refer to no one because like organizations are not going to be, so that it's not ready yet for that piece. That's why we're taking those 6 months. Additionally, many of you who work in clinics, primary care, or are providers, you know that you have like staffing challenges, particularly in primary care, right? You may have a care coordinator, or you may not, or you may not have a navigator. We are currently exploring a partnership so that we can better utilize the state plan amendment that was done almost about a year ago now, so that community health workers can be trained to use the platform and perhaps produce a staffing model that can support PCPs, primary care providers, and particularly rural hospitals in taking advantage of the community health workers' like ability to build Medicaid and sustain in that sense. And not only go to PCPs with, here is a platform that you can use for free, but also here is a staffing model that could be working. We're actually also working with the ECHO project to do a few sessions on that piece of like staffing and how can you coordinate your clinic so that you have the capacity to really participate in this closed loop referral system from that perspective. I'm going to move on to the few next like slides. This is kind of what it looks right now. Yes, New Mexico. When you go into Yes New Mexico, there's a couple of ways in which you can now go to Yes New Mexico Connect, which is the closed loop referral system, which will allow people to enter their zip code and find programs. I'm going to stop with this like slide here, and this is the last one I'm going to share. This is a diagram of the desired partnerships within the closed loop referral system, which speaks as to the possibilities. What you're looking at here is SP stands for service provider, any community-based organization, any organization that is providing a service to individuals. The Yes New Mexico Connect platform is free to all of them. The houses, or the roof with columns that you see in the circle, those are counties. And I'm looking at Doña Ana County here, and Jamie, who is participating as one of the pilots and really one of the first counties to jump on board. Each county will have a license so that we can actually develop partnerships at the county level too as well, and let counties guide us as to how do their networks look, where are the gaps, and how can we like strengthen our ability to collaborate. The same for tribal nations. We are hoping to engage with all of the tribal nations in the state. And then what you see here in the middle, it's instead of a more county localized geographical approach, it's more like those organizations that have like, I'm going to say their tentacles, their reach large enough that they touch on this, the entire state. So for example, NMDOH, and I see Janice here, we are starting to talk, well, we've talked with the secretary as well as we've talked with Susan Garcia, with Health Equity Director, and Miranda Durham, who is the Public Health Division Director, to see how is NMDOH going to be joining. We are still in conversations in defining that. But the same has happened with ALTSD. With correction departments, there is a pilot project going on. Hopefully, they're going to decide to participate. ECCD, we are not there yet with the collaboration, but we are also hoping that they're going to be able to participate. The 211s and the 988s, we've had a couple of meetings as to like how to join forces here as well, and there are very good we're moving in a positive direction. The MCOs, 3 out of the 4 MCOs already have contracts with this platform, which means that soon enough, they also are going to be able to start using the platform. And then in terms of hospitals, UNM, it's one of the largest hospitals that's joining the effort from the get-go. Why I'm sharing this, I think this is the potential. The platform is just a platform, but what it helps us is to build relationships and hopefully break some of the silos. It's impossible to break all the silos. We live in our own context, in our own organizations, and to a certain extent, that's never going to disappear. But at least as we have this platform connecting all of us, it will allow us to then hopefully go into that phase of, okay, now that we are connected, what other ways can we work together to eliminate some of the barriers so that people can thrive and access services? I'll stop that there. And if you have any questions, any primary care providers that may want to touch a one-on-one with us and have a conversation about this, we'd be willing to have. I'll put my email in the chat as well.
Thanks, Roberto. Questions, comments?
This is Jamie. I just have a couple comments. First, our local FQHCs, we're very excited about this because it can truly integrate with their electronic medical records, so it's not going to be 2 separate systems. So our FQHCs gave it a thumbs up, and we're excited to begin using it. And then not really related to this group, but mainly for the HCA folks. If we can also use this as part of the bridge program and have emergency departments use this to do their SBIRT and make their referrals for MOUD and other services, I think that will help it catch on more with hospitals. Thank you.
Thank you, Jamie. And one of the reasons why we selected Find Help is because we actually were able to see, touch, try the integration into electronic medical records. Many of them actually, not just the larger ones. And yes, it's very exciting that that's a possibility as opposed to just a link in your electronic medical record that takes you to another page that then you have to log in again, etc. It's an integrated workflow within clinics and electronic medical records. Thank you. Any other questions? Or is it like noon and that's kind of the time of the day?
Mine's 2 o'clock. Now I'm okay at noon, but thanks, Roberto. Anyone else?
Well, thank you so much. I've added my email in the chat. Please feel free to reach out to me if you have any questions. I would love to chat and provide you with direction or information or resources if we have them as well. So thank you.
Thanks, Roberto. Okay, well, we're still doing good on time, even though we're running a little behind, but I think we're doing all right. We're kind of at the end. Val, if you wanted to say anything, and then I've just got a couple logistical things. So
thank you. No, I mean, I think again, there's just so many exciting things happening in the state, as we've heard. Really great to get some of the information on closed loop referral and the behavioral health funding. And again, just really appreciate everyone's work, particularly that the committees are doing to help guide the PCC's work as we enter a bit of a new era. And I don't think I have anything else particular to say other than to Matt's point, we got to keep up the good fight and do everything we can to protect primary care access for all New Mexicans.
Well said, Val. Yeah, I just have a couple kind of housekeeping logistics for the group. So as Val said and other folks, I think we're calling them different things, but the subcommittees or work groups are the same. So these are the current ones that we have. And as I mentioned, the behavioral health integration is our kind of latest one. I can't remember who recommended it, but I think it's a great idea. So that was the additional one that's been added recently. So if you have any interest in any of these work groups, if you're not part of them already, you can go ahead and email me and I can let you know. We've kind of set a normal cadence for all of them on a monthly basis that people have been meeting. For next meetings, these are the next three on the list, and I think it follows our normal cadence, the second Thursday of the month of the quarter. So that is still the plan. If anyone has any concerns with that, I guess let me know. For future topics, so we didn't do it today because we pivoted a bit to have the discussion around the PCC priorities. But going forward, I think it will be helpful to have sort of a report out from those work groups from a representative to get any feedback or thoughts as they continue to work on some of the goals. So that's what we'll be planning. Also, maybe some discussion around membership, just revisiting if some folks, have not been able to attend for a while, discussing maybe more recruitment and just getting some different folks in here that have the capacity. I don't know how you all do it. So it's a lot doing your primary care work and then also joining these type of things. And I'm sure you have many others. So that's another possibility. I know Maggie would really like to talk about the dashboards, which I think we'll queue that up for the next quarterly meeting, as well as future funding. Nope, I'm missing an O, but legislation, obviously, those all seem like really pertinent and important things, especially related to our goals. And then just any other policy changes and again, updates on the OBA. I think obviously people are going to want to know. So when we have that available, we can do that at the next quarterly. But yeah, any ideas you have for the next one, I'll be sending out later today a doodle for the next steering committee to discuss some topics and then another one closer to our next quarterly. But that's all I have. Anyone have any other comments or thoughts on any of that?
And you said the PowerPoints are available.
Yes, Maggie, I attached it to the calendar invite. Some people have different ones than I do. If you have any issues, just let me know. I can just go ahead and send you the PDF. I'll try and post on the website today or tomorrow the link on our primary care council. So if folks ever, are wondering where that stuff is, along with the recording as well. So that'll all go up hopefully by the end of the week, maybe early Monday. There's a lot going on, but I'll try and get up there as soon as I can. But yeah, feel free to reach out to me with anything. I think I've already seen some emails coming in, but I haven't read them, but feel free to reach out to me with anything. So, okay. We still somehow ended early, so it'll be nice for people to go have some lunch.
Good job. Thank you.
Yeah, thanks everyone.
Bye.
Have a good day. Bye.